Yesterday, for the people who are not around and for the whole week, we have been looking at clinical nutrition. We had a brief introduction, then we looked at enteral nutrition, then we looked at the oral nutrition supplements, then we went ahead and further looked at parenteral nutrition. We looked at both types, the peripheral parenteral nutrition, and also we looked at the total parenteral nutrition. We looked at total peripheral parenteral nutrition in a sense where we are looking at the extremities, all those body parts that are not on the central circulatory system to help us deliver the feed directly into the bloodstream. We looked at the catheters being located on the legs, on the head, on the legs and on the hands. Then for the total or central parenteral nutrition, we looked at uh, directing the nutrients into the major veins of the body that are located on the central part of the body. We had looked at those under the nutrition interventions. If you had gone ahead and looked at positioning the topics in our nutrition care pathway or the NCP or nutrition care process, you could say, that would be the nutrition intervention that we are looking at. So, but remember, the first step of the NCP was the nutrition assessment. Okay, from nutrition assessment to nutrition diagnosis, then from nutrition diagnosis to nutrition intervention, then from nutrition intervention to nutrition evaluation and monitoring. So, friends, today we'll interest ourselves with the first step. However much we have looked at the third step, but you will get away of organizing them when you're discussing or when you're having them stored in your brains. So, going forward today, we will be looking at nutrition assessment, and this is very key for every nutritionist out there. Okay, this is very key for every nutritionist out there. It would be very challenging if a question came about nutrition assessment or nutrition status assessment, and you can't able tell people what other forms of assessment, what are the methods of assessment, etc. So, friends, we will interest ourselves with understanding what are the methods in there and how can we grasp them easily. Most of some of the things that's why I really like people to attend the lectures, because some of the things are not in the slides, but then I talk about them. So if you're around, then you are able to pick them up. Or when you're listening to the audios, you will be able to pick them up. For the nutrition assessment, we are saying this is a process of evaluating an individual's nutrition status, and we have the different forms of the categories of nutrition status. We have underweight, we have overweight, we have obese, we have the normal nutrition status, etc. We are saying it involves collecting data on various aspects, including the dietary history, lifestyle, medication, medical intake, social and medical history, then the anthropometric measures, the biochemical measures, or we could call them laboratory tests. Here we are looking at the liquids or the body fluids that we are trying to assess for those nutrient deficiencies, such as the iron under the HP test, etc. Uh, Friends, when we talk of the nutrition assessment, we need to have the ABCD, okay? The ABCD nutrition assessment. One would be anthropometry, that would be A. Then for B, we would look at the biochemical assessment. Then for C, we would look at the clinical signs and symptoms, whereby here we are looking at a person's appearance, and this will inform us further on what deficiencies they might be suffering from. However much this is the clinical assessments are always not as conclusive, then we do the lab tests. That's why we are saying that we would not encourage to have one method done. We would use one method but choose the other as confirmatory. Then for D is where we look at the dietary history or we do dietary assessment. All right. So let's begin with dietary history or dietary assessment, and we are saying this is a common method of assessing food intake. Okay, and we are saying this typically includes. Please mute. Please someone mute. I'm having a lot of feedback this side. We are saying it typically includes usual dietary and meal plans, what foods and drinks are consumed in a day. This is where we look at the 24-hour records, the food frequency questionnaire. Then we have food records. These days there is a new tool that actually monitors everything that you're supposed to be eating, and actually even it weighs. Okay, for people who are practicing nutrition in those high-end or developed countries, they have these particular systems that measure. I don't know, it's more of an algorithm, and it is being tested out, whereby people put in what they've eaten and it will do everything. Actually, it looks as if it is a surveillance system on the other end. Yes, is someone trying to communicate? Having a lot of feedback. Whose mic is open? Uh, Sarah's mic is open and Ral. I'm having some noise in the background. Please mute.
But on my side, you see this link is very difficult for us to mute
Oh,
even
right, it's fine. It's fine. I hope we don't disorganize the class with that external noise that is coming in. All right. I had talked of the 24-hour recalls. We had talked of the food frequency questionnaires, and these help us in assessing dietary diversity, and also they help us in assessing food intake. Okay. And we will see in details as time goes on what are the challenges, what are the limitations of the different nutrition assessment methods, or I would say. So here we are looking at the number of meals, how many meals or snacks eaten per day, the meal size, the typical portion sizes, and the plates, etc. And the location of eating, where meals and snacks were taken, typically eaten at home, work, or at a restaurant. And this would help giving us information on the lifestyle and the food choices of that individual. You realize that most foods cooked at the restaurants, leave alone the restaurants that are key, that have these nutrition considerations. Most of the foods are refined foods. You'll find that the restaurant that is that is attended to most by people where they take their wives for outings or girlfriends. Most of these restaurants prepare refined foods, okay, or highly refined foods. It's either the chips, it's either the chicken, the liver, and all those other foods. And also we are looking at the snacking. Mostly right now in our day-to-day lives, we can't go without a snack. Going along, using myself as an example, when my day starts at around my actual day starts at 7:20. That's when I wake up and go to work. You realize from 7 to 1, that whole period, I don't have any meal. It is only a snack. Okay. And then sometimes I'm even still caught up in the field by 1. However much it is a lunchtime hour, you want to complete most of the tasks that are embedded within. So what you do is just push lunch forward. Most people who are working understand this. We tend to always limit time, and we want to achieve people's results very early compared to our own health, but there is nothing we can do at the end of the day. We need to survive. So those are the things that when someone tells you they're having a lot of snacks, then you can determine what are the impacts, what is the lifestyle choice this person is having, and you can advise. Therefore, for example, if someone tells you they're over snacking, then you could advise them to pack their own meals and go with them. We will engage further on these interventions as time goes on in our lectures. Okay, so information collected from dietary issue, we are looking at consumption of ready-made meals, the snacks, the fast foods, like I had said, and how often these items are consumed. Okay, then the fluid intake. I think you remind me. I will share with you a template assessing household dietary diversity or a 24-hour record. I will share those templates with you people so that you get a feel. And these are the most common methods of assessment, because if someone is doing their research mostly undergraduate or diploma, in most cases there is no money. You're not having a grant at your disposal for you to squander money on laboratory tests. However much they would give us conclusive evidence of what is there, but really we feel that by you taking all consideration in collecting all this information, of the dietary history, food frequency questionnaire, using food frequency questionnaires and 24-hour recalls, and food records, and all that will give you the correct information and assumptions. Then we look at the fluid intake, amount of water, beverages, and alcohol consumed. We look at the food allergies and food preferences. We look at frequency of consumption, how often certain foods were eaten compared to other foods, and why those foods were chosen. Is it because you wouldn't afford the other preferred meals, etc. Well, that's where we look at the food consumption scores, and we start scoring the different foods, how the individual consumed them at the end of the day. We have strengths and limitations, and we are saying with the strengths, when we do this dietary assessment using a diet history, here we can provide a detailed picture of someone's usual diet, and we will see that when we come to doing dietary history, or taking doing the dietary assessment of an individual, we choose random days. We can't go collecting data or collecting information when we are in a Christmas period or on those festive days. Okay, because what type of data are you going to collect? Someone will be telling you, I ate meat yesterday, I ate meat today. For example, in our household, when it is Christmas, or when it is those days, even if it's in a Muslim setting, if you go and ask people a 24-hour recall and ask them from right now at 8:35 to 8:5, and you're assessing them at 8:35 on Wednesday, and you start asking them, taking for example today was Eid, they will tell you that they ate meat, and that will give you a wrong assumption and a wrong result. So we discourage people taking data on those festive days. I hope you understand that. And we need to mark them off. For example, if you're sent to the field and you know a public holiday is going to fall within, you can argue with your supervisor and tell them that, okay, I would have collected the data, but having this, we would have to downplay all the data that is given us on those days. Okay, and also not only are we looking at the festive period, but also we are looking at the fasting period. Okay, if we go to a home that is observing a fast, and we are trying to collect data from them, what happens is they are going to tell you that they ate fewer meals compared to the meals that they were supposed to eat. However, it will start varying in the amounts of meat, of food they ate at the end of the day, but then you will be getting wrong results and wrong information. And also, we are saying it can be used to assess the quality of the diet. Most of these questionnaires have those things, the condiments, oils. It will have the different foods from the different food groups, and it will show a person whether the person has balanced the foods, whether a person is taking fruits and vegetables, whether a person is eating whole meals or whole wheat, whether a person is eating highly refined foods, etc. And we are saying it is relatively inexpensive and easy to administer. Any of you can wake up in the morning after having a template, go through a few engagements, and I hope most of us have done this data collection as a side gig whenever we needed to get some extra money to keep us moving. So what you do is you're organized well and you're briefed on how to administer these questionnaires. We won't go to that, but I hope you understand. So then the limitations, we are saying it relies on memory. If someone can't remember, then they won't tell you or they won't give you information, because we always forget those simple things, such as the snacks mainly. If someone had asked you right now how many snacks you've eaten, you might say, I've not eaten any snack, but then you forget someone gave you maybe a palm full of groundnuts, a handful of groundnuts when you're moving, whether you ate some popcorn somewhere. Maybe if we are talking of beverages, you will forget that you had tea or coffee somewhere. Then you will forget that maybe you drank a soda or you sipped on a juice or something like that. So that is the inaccuracy that comes with that. And they're saying it may not be representative of long term dietary patterns, because these fluctuate, like I told you. If we go and assess people in days that they are eating well, it wouldn't give us the correct picture. However, These can be submitted to populations that are stable. For example, the diet plan or the meal plan of a prison is well known. A meal plan of a school is well known. However much people can argue that there are canteens at schools, etc., but here we could administer these exact 24-hour records or dietary assessments to people who are stationary, and we know what types of foods that they are able to be eating regularly. Okay, and we are saying it can be time consuming to administer and analyze. If you've seen some of these templates, a little broad, but depending on what you want to really look for. The problem with us as people who go to the field in most cases, and I think this goes to people who are in the meal department, the monitoring and evaluation teams, these people tend to draft along tools that assess almost everything, and even information that they won't use or information they won't analyze, they will leave it there. But what I know is things are not cast on stone. Okay, whenever you sit down in a class, what you're getting is information, and you will choose which information to use when best needed. Okay, so what are the advantages of the 24-hour recall method? We are saying this is easy and quick to administer, like I told you, and it does not require special equipment. Okay, this can also even be done on phone. Okay, you could call someone right now. I might not be physically present with someone. I will just load airtime on my phone and call a person, and then administer the tool on the phone. So it doesn't need me to meet someone physically. However much it is very very uh, what should I say? Bias is always something that will happen. For example, if in most cases there is a famous story of a lady who was being asked by the doctors, "What did you eat yesterday?" And looking at the doctor, I think she was trying to play that she's a high end, yeah, or a high class lady. She started saying, "I ate chips, I ate chicken." But the problem is when you deceive a patient, when you're a patient and you deceive a doctor, problems happen later on. So when the lady, I think she was nauseated and she started vomiting, and from the person's vomit you can always see what that person ate, and the person who was claiming to have eaten chicken, there were a lot of beans and all that stuff, the eggplants. It was all in her stuff. So that is the issue. It's that bias is already there. Okay. Yeah, but then you make it a little open and say, I'm not going to crucify you if you tell me the exact food you ate. And we are saying it can provide information about the recent food intake. The other thing is with the 24-hour recall, however much it would be a disadvantage and an advantage at the same time. Looking at the food frequency questionnaires, I think 24-hour recalls are better at memory because at least the chances are 85 or 90% that I will remember everything I ate in the last 24 hours compared to giving you food recalls, weekly food recalls, or telling you to giving you a food frequency questionnaire, etc. I may miss out on some things. Okay, and we are saying one of the disadvantages it relies on memory, which can be inaccurate sometimes. But I've said it is better than some different forms of assessing dietary intake. And we are saying it is not representative of long-term dietary patterns. And like I told you, there is a subject to bias such as underreporting or overreporting. Sometimes someone will tell you they ate a lot, but then a lot is relative. What is a lot for me might not be a lot for you. Okay, yeah. Then there are those hand measurements, a palmful. There is ladles and etc. There are a lot of things you will go and read at the end of the day and see how challenges may come. So, friends, let's interest ourselves with anthropometry. With anthropometry, whenever you hear the word anthropometry, you're looking at measuring. Okay, yeah, we are looking at measurements, body measurements at the end of the day, and we are saying this refers to comparative measurements of the body used to assess our nutrition status. Okay. Yeah, these are useful for infants and children and adults. Here we will take the length, we will take the height, we will take the weight, and we will take the weight for length, weight for height, etc. and also height for age. I think that one is for stunting, the others are for wasting, and also looking at the also this is where we come with the mid upper arm circumference. I hope we know how to take more. Friends, I hope we do know how to take more, okay, because that one might be an assessment area for you people. Because these are the rapid nutrition assessment methods that we have 1,000 children who are arriving. We are in an emergency. These are refugees coming into the country. So what do? We will have to employ those rapid nutrition assessment methods. And one of these is a mid upper arm circumference. Because it is not invasive, what we do is we will have to just take the mid upper arm circumference and categorize the children in their different nutrition status or categories, as we will be seeing. Okay, so introduction to estimating height, and we are saying estimating height is crucial for patients who are unable to stand. Okay, yeah, and if a patient is unable to stand, what do? We take recumbent length. Okay, but then we also have other methods such as the demi span, and also we have the knee height. So we are saying it is important and necessary for bedridden patients whose spinal curvature or lower limb are dysfunctional. And this is the same reason, for example, if you are at an interview, they will ask you, why don't we take height for pregnant women? Okay, this is still the same issue. We believe when a woman is pregnant, there is that distension in the spinal cord. So, in any aspect, when we try to take the height of that individual, we might fail to take an accurate measurement. All right. With the demispan, we are saying this measures from the tip of the middle finger to the sternal notch. Okay. Do we know the sternal notch, friends? Yes? Hello, please talk to me. Do you know the sternal notch? The sternal notch is, let me try to get you an image here. Yes?
Yeah, the picture is visible.
Yes,
Visible.
Yeah.
yeah, it's visible.
So where my cursor is right now is the sternal notch. Okay? Yeah. So demispan, we are measuring from the finger, okay, the fingertip to the sternal notch. Okay? Then it is computed as follows. Okay? Are we together?
Yes,
Yes, we are together.
All right. Then we will go to the knee height method. This measures the knee height using a sliding board bladder clipper. Some people use tape measures because that is what is always available in our setting. Uh, so the patient is in supine position and the caliper is placed on the heel with the knee and ankle at a 90 degrees level. Okay, then still these are the calculations. Okay. All right. So evaluating body weight and the ideal body weight. Ideal body weight. These calculations are more to do with the pounds and also the Hamwi method of calculation. But really, most of the times, what we look at here in most of our settings is calculating the BMI. And for the people who will be positioned in hospitals or positioned in these clinical settings of ours, we usually take a BMI to be of key importance. If you're a nutritionist or if you claim to be a nutrition practitioner and you can't calculate BMI, which is a very simple calculation, then there will be issues because it is also an area of interview when you apply for these jobs. And it is basing on they give you the weight, they give you the height. Actually, they will only give you the weight and height, then they ask you for the nutrition intervention that you would do depending on that person's nutrition status. Okay. Yeah. Like I've said, this is a widely used method of estimating body fat and assessing weight status. Uh, and also, we are saying that it was developed by that gentleman, Adolf Quetelet, and it is used by dividing the individual's weight in kilograms by the square of their height in meters. When we say a square of the height, if your height is 175 centimeters, that is 1.75, right? So when we square it, in most cases, the challenge is when people are calculating BMI is they multiply by 2, which is always challenging. But then it should be multiplied by its own value. Are we together? So if it's 1.75, then we multiply it by 1.75. We don't multiply it by 2. That is the most challenging, and it gives very incorrect results. I don't know how busy you were, but we will go through some questions, uh, hopefully this week or next week, about how to calculate the body mass index. And we are saying that this serves an indicator for body fat stores, and it is associated with increased risk of illness and mortality. Okay, yeah. So the BMI formula, like I've told you, it is weight in kilograms divided by height in meters squared. For example, a person weighing 70 kilograms and is measuring 1.75 would have a BMI of 22.86 kilograms per meters squared. Okay, yeah. For this, in most cases, this is the US customary units, but we mostly look at the kilograms. Okay, for us, we use kilograms divided by meters squared. So, is it okay if we can give a small assignment for us? Friends, talk to me.
Ah,
Yeah, you're going to
I think this one is very simple to be calculated
yeah. So
because yes,
that's why I want to give a simple one.
yeah, this is very simple to be calculated because
Mm,
this 1.75
mm,
multiply by 2, then
mm,
we'll give you the number, and this number you divide by 70, then we'll give
yeah.
you the yeah.
Okay. So the challenge is at the end of the engagement, I want us to to replace the 70 kilograms. Okay.
Mm,
I want us to replace the 70 kilograms with 90.
there's no problem.
Yeah. So you write somewhere 90. Then for the height, we are going to be using 1.54.
Okay,
Have we written?
yeah, we have written.
For the weight, we are using 50. For the height, we are using,
For the way we are using 90.
for the weight, we are using 90. Then for the height,
For the high we are using 1.75
no, we are using 150.
or one. Okay, 150. Yeah.
Yeah. All right. So let's proceed. At the end of the engagement, we would get some information. So the BMI classifications, these are standards. Okay. These are standards that we are not going to argue about. And for underweight, it was discovered that if we calculate your BMI and it is less than 18.5. Okay. So though some people argue 18.499 etc, but really if we talk of 18.5, then that is 18.5. Then for the normal weight, we are believing that if someone is falling in a range of 18.5 to 24.9, we will classify this person as to have a normal nutrition status. However, when we go to these boot camps and we are trying to counsel people on diet on lifestyle and etc. Whenever you tell someone that you're in the normal, even if someone is having 19.1, and you tell them that you're normal, you're having a normal BMI, what they will celebrate at the end of the day. But you can really know that in the next, let's say, 2 months, if you continue eating the way you're eating, if you continue missing meals, for example, if someone is a 19.5 and they fall sick in the next 2 weeks, they get some chronic sickness, what happens? This person will be easily balanced. So we want as much as possible to advise people to be around the middle. So the midpoint is around closely 20.5, 21, you're good, 22, you're also good. We want people to be in the middle. That even if you fall, you're not falling a lot, or even if you overeat, you're not going to become overweight at the end of the day. The overweight, we're looking at it being at 25.0 to 29.9. Then we have the obesities, class 1, class 2, and the extreme obesities, what we call morbid obesity. I think you've seen those women who are really fat. Okay, fat is a bad statement. Please never use it when you're addressing people. You can't say that woman is fat. Okay, it's not very polite. So I apologize for that. But people who really have a lot of weight on them, who even can't move, yeah. So we could look at those. So we are saying individuals with BMI of less than 18.5 at increased risk of mortality, because once we realize that. What does the body do if you're not taking in a lot of, let's say, calories? What will the body do? The body will start breaking down the protein or your tissue to get energy, and that is the energy it will be using to run these day-to-day activities that it is supposed to do, the breathing and all those vital signs to keep active. So you will become emaciated because all the energy that would have been spared if at all you are putting in the carbohydrate is now being gotten from the tissues and of the body, etc. But likewise, now the burden is no longer more on the underweight. There is a high, actually, the burden is more on overweight. Okay, that is the triple burden of malnutrition in these days. These days, the triple burden of malnutrition. People used to only look at underweight, but now we have underweight, we have overweight. Then the other one that is always silent is the micronutrient deficiencies. Okay, someone can have a normal nutrition status, but they are deficient in some micronutrients. So when someone talks about the triple burden of malnutrition, hopefully we can be able to understand. What you're seeing here is a physician trying to measure the height and the weight at the same time. Okay, these are machines that can actually show you the height and the weight. Though there are also some machines of the infrared, infrared technology using beams that can also tell an individual's height really very very accurately. Also, wouldn't want to skip this. We need to know the exact steps we take when we are taking height. We need to know the exact steps we take when we are taking weight. We need also to be very knowledgeable about the standardization of these tools. For example, recalibrating the height boards or realigning the weighing scales. Then we need to know how to take 2-in-1, etc. When we are measuring, for example, the children who cannot stand on their own, that tearing of the weighing scale. Hopefully, we have a session on those. Really, we have always very limited times for these engagements, but I hope we'll always have time on weekends to catch up with every place that we will feel that is already a little bit insufficient for us to handle. Okay, BMI and health risks. We are saying BMI and the risk of obesity related health problems, the type 2 diabetes, the hypertension, the cardiovascular diseases. When we talk of cardiovascular diseases, we are not only talking of the heart, but we are also talking about those veins and the blockages that could happen in there. So we are looking at increased risk of diseases associated with BMI and waist circumference. These diseases are a group called metabolic syndrome. Okay, because we believe by you having one of them, the other is bound to develop. Okay, yeah. For example, if you have type 2 diabetes, if not well managed, hypertension will come in somewhere there. Okay, and we are saying type 2 diabetes affects how your body uses the sugar for energy. Okay, so it stops that antagonizing reaction that comes from the insulin, and this will lead to high blood levels if not treated. Okay, so it causes a lot of damages. I know you people have heard of the diabetic foot where people need to be amputated, but then it is always very crucial. That's why general body checkups are always required, however much some of us make them very uh, expensive at our places of work. I don't know why, but I think it is more of a money making venture. So, limitations of the body mass index. Body mass index also, however much it is a good tool, and we've seen how we calculate it. We are saying the BMI may not directly correlate with body fat, okay, and uh, correlate with body fat accumulation of all individuals. Exceptions include athletes with high muscle mass who may have a high BMI but low body fat. Okay. Muscle mass is also weighed when we are taking our weight measurements. So instead of we could say, okay, now for you you're having a lot of weight for your height, but then this weight is muscle mass, and we know what muscle mass is. Okay, until this person cannot give the body a carbohydrate, or the body is not taking calories through carbohydrates, then that's when it will resort to uh, the muscle mass will start diminishing. But unless otherwise, you may think the person has a lot of fat, but ideally it is muscle mass and it is protein, which is very essential. Excuse me, which is very essential for the body. And we are saying BMI alone cannot provide a comprehensive assessment for health status. That is why I said we need to know these methods of assessment, so that if we did this, then we would maybe do a dietary assessment and couple up with the information that we've got from a 24-hour recall or a food frequency questionnaire. We can now easily tell the individual, or information we've got from dietary history. We can now get a information that we could sell to someone. For example, right now, if someone came presenting overweight, then we would look at their dietary patterns, and you would see a lot of snacking, you would see a lot of eating food of large volumes, or the quality of food they're eating, whether it is highly refined, whether cooking oil they just decided to not only eat but also drink it. I don't. Right. The waist hip ratio as a nutrition assessment tool, we realize that a lot of fat is distributed around that area. Okay. Yeah. So in most cases, it's what we call the abdominal fat, and the waist hip ratio, or the waist circumference to hip ratio, it estimates the distribution of fats and the risk of disease related to central obesity. And we are saying research suggests that the waist hip ratio and the waist circumference predict heart disease and strokes better than the BMI. Yeah. The waist hip ratio values above 0.95 for men and 0.8 for women indicate a heightened risk of heart attack. Really, and we are saying healthy levels of waist hip ratio, we are looking at 0.7 for women and 0.9 for men. Friends, when you're doing practice or wherever you are, please have these things pinned up. Trust me, the only way you can remember cutoffs is by pinning them up. No one can have cutoffs, okay, though some people have them due to experience and the like. But have cutoffs, have these charts pinned up on your walls whenever you're practicing. Or even if it's not that, however much opening a book in front of a client shows a little lack of confidence in what you're doing. But I really advise maybe you open a book than deceiving. Because you're not the only nutritionist in the world. The other nutritionists and people have practiced for a lot of time. You're not the only health worker. People have done this work over and over. However much of the new graduates that we have on board, please don't take this as a moment for you to say, I know it all. Consult a book, open up a book, open the Imam guidelines, open all the guidelines that are there. Okay? Yeah, if at all they have the correct information, don't get afraid of opening a book in front of a client. And trust me, once you open a book or you're reading from a chart, that thing will get stuck into your head slowly by slowly, because the more you look at something, the more it gets into your head subconsciously. There is circumference. We are saying there is the picture here is a misplaced picture, but this is how we take the waist circumference. In most cases, they touch the belly button. That's where the measuring tape starts from. We know what the belly button is, that area that she's touching. Okay, then they rotate the tape measure around you and take your waist circumference. All right, then we are going to shift and look at a biochemical assessment a little bit. We are looking at biochemical markers which reveal nutritional depletion and play a crucial role in nutrition evaluation, looking at measurements for vitamins, minerals, and other metabolic products in blood. Okay, we know what a metabolic product is. What is at the end of that enzymatic reaction that has taken place. And also we are looking at the urine and the sugar and other biological materials, serum proteins such as the serum albumin, which is a useful marker of the nutrition status. Low serum albumin levels always indicate poor nutrition conditions and a high risk of mortality. All right, serum albumin as an indicator, we are saying this is a level. The serum albumin level is an indicative marker of the nutrition evaluation, and we are saying it has a relatively long half-life of 21 days. And we are saying low serum albumin can signify a poor nutrition status. The pre-albumin lower levels in malnourished patients indicate severity of illness, sensitive and cost-effective method of assessing malnutrition. Serum creatinine indicates muscle mass and renal function, and also a simple test commonly used for nutrition assessment. However much we always rely on these, but in most cases we know. But by the time we have these biomarkers or these nutrition markers coming into play, it is just trying to confirm, but already clinically we are seeing you emaciated and we have done maybe the, if you can't stand, then maybe we have also taken the mispan and all those. Like I had forgotten to tell you about geriatric nutrition, that we take a demispan in those elderly individuals or the old age, because we know as you grow old, in most cases, according to our nature, our structure tends to bend and our spine tends to bend, and you can't put my height together. So what we do is usually we also use a demispan of those. Other nutritional markers, we have the serum transferrin, and we are saying iron transport protein used as a marker for the total nutrition status of iron deficiency. So the transferrin receptor levels indicate tissue iron status, and we are saying the increased serum soluble transferrin receptor is a sensitive marker in iron deficiency. So with its increase, it shows that the iron is being depleted from the tissue. So identifying special nutrition requirements here, these are the parameters like I told you earlier on. Really, what we have here is more of you could interchangeably use them according to how best you see. But like I told you, it is A, B, C, and D. Okay, A, which is the anthropometry, B is the biochemical assessment, C is a clinical assessment, and D is the dietary history or dietary assessment. Okay, so subject global assessment, the identifying the special nutrition requirements. Here is where we'll see the recommended dietary allowances, the protein requirements, and etc. And we are saying these are customized, and usually our lecturer, when I was still doing my undergraduate or my bachelor, would say not a one size fits all. Okay, it's not that your shoe size is going to fit me, and it's not that my shoe size is going to fit you. That with nutrition, we have to play around with the knowledge that we've gained, but we use it, linking it to those particular requirements or those particular conditions that are supposed to be met by our intervention that we are trying to put forward. The essential macronutrients vital for body structure and metabolism, and the daily requirement of the protein is 0.75 to 0.8 grams per kilogram body weight. And this is measured by nitrogen excretion and total losses for accurate measurements. Estimating carbohydrate requirements, we know the roles of carbohydrates in the body, prepare the sparing effect of protein, they are being them being the main fuel source of the body, and etc. And we are saying the total requirements expressed as a percentage of the total energy intake, 45 to 60% for adults, and the recommendation is 39% from starches, milk, sugars, and intrinsic sugars, and maximum intake of approximately 400 grams for the adults. Okay, but remember, like I told you, these are not cast on stone, and they interchange depending on the physiological needs of the individual. For example, you're not going to give the same amount of requirement of carbohydrate for a woman who is pregnant. Remember, she's also supposed to be feeding the fetus, and you're giving them to a man, or you're giving them to a toddler or a school-going child, or you're not going to get the same amount of energy requirement for a person who is doing manual labor and give it to a person who is already seated and doing sedimentary work. Okay, then estimating fluid intakes, this varies depending on individual factors such as gender, age, and activity level, and also climate. And the recommendation is fluid intake should cover for total losses with additional intake in cases of high temperatures, since with high temperatures we look of increased losses through sweating and through urinating, because the body wants to cool down the system. And also we are seeing increased losses due to illnesses, through people illnesses, those conditions people would get, such as the diarrhea, the nausea and vomiting, and etc. The recommended intake is around 500 to 750 mils, greater than the urinary losses if we have taken into account the urinary losses. For children, really, these are just recommendations that if someone would walk into your a consultation room and ask you, these are things you would open up or you would look at on the charts and really tell them through them. For children's 1.5 mils per kilogram of body weight, and for adults 1 mil per kilogram of body weight, or 30 to 35 mils per kilogram of body weight. Biochemical markers for dehydration, urea creatine ratio greater or less than 0.15, elevated levels of plasma sodium, urine color or specific gravity, serum osmolarity, and also for health problems associated with dehydration, we have constipation, medication toxicity, renal failure, urinary tract infections, elevated body temperatures, and dizziness and weakness. Okay, so people at risk of dehydration, the infants, the young, older adults, people with eating and swallowing difficulties, individuals with undiagnosed or uncontrolled diabetes mellitus, and also patients receiving diuretic drugs. I hope you know what diuresis is. If you don't know, I think we will talk with the administration and see if we can have one on drug nutrient interactions, at least one of. All right, so friends, I think this brings us to the end of our today's engagement, and really, hopefully, we can take out a few from these. What I would want you to know is you you could choose to use a method according to what type of information you want. Okay, if you want information beyond reasonable doubt, then you will go and look at the laboratory assessments or the biochemical assessment. If you're correcting your research, if you're submitting surveys, if you're time barred, then dietary assessments will work, or clinical assessments will work in form of emergencies. That's the clinical assessments when we look at the deficiencies, micronutrient deficiencies, such as the sparsely populated hair, angular stomatitis for vitamin A deficiencies, those corneal ulcerations, etc. They will be able to show us. Then even the slow capillary refill, I hope some people have done that, whereby they apply pressure on on the on the fingers, okay, and then that one will show whether a person has a lot of is it the hemoglobin. It is then also when people are testing for edema, that pitting edema, bilateral pitting edema, which is a sign of malnutrition. So all these things you can assess. It is about you having the information and how you can use it adequately to give you results. So friends, I beg to end here unless we have any concerns.